when you have a situation like the coronavirus, they are suffering disproportionately. As Dr. Berg said correctly, it's not that they're getting infected more often, is that when they do get infected, their underlying medical conditions, the diabetes, the hypertension, the obesity, the asthma, those are the kind of things that wind them up in the ICU and ultimately give them a higher death rate.
These factors, and I'm paraphrasing a bit, include first, higher rates of certain pre-existing conditions in the group, including diabetes, hypertension, and obesity. Second, the fact that people of color form a disproportionate portion of the essential workforce outside of the health professions. And third, the existence of implicit bias and racial discrimination in our society that continue to produce structural inequities and social determinants that can lead to negative health outcomes.
As it has been proven by the CDC, Black and brown people of color are more likely to die from coronavirus due to underlying conditions. That risk factor increases with the number of underlying conditions a person has. But why do minorities suffer from these conditions at such alarming rates?
Now, if you look across the United States, the Southeastern Conference is good for football, but bad for cardiovascular disease. In those areas, starting in East Texas, Louisiana, Mississippi, Alabama, Georgia, into the Panhandle of Florida, North and South Carolina, parts of Tennessee and Kentucky, and even into Appalachia, there are high rates of cardiovascular disease, including heart attacks and strokes. In these areas, you have a large number of persons who are uninsured. This uninsured status leads to poorer outcomes. People who cannot afford medications cannot have access to care. Now, one realistic component of this is a large proportion of African Americans who live in these areas.
Not only do Black and other minority communities suffer with obtaining adequate health insurance, but there is also an issue to be raised about the lack of quality and available health care within these communities.
American housing policy provides an excellent example of how structural racism can influence health outcomes. Before the passage of the 1968 Fair Housing Act, it was legal in the U.S. to discriminate in the sale, rental, and financing of housing. This meant that people could be legally forbidden from living in certain communities. Since health is influenced by the quality of one's living environment, this put many Americans of color at a disadvantage. In her recent article, Michelle Gordine explains that living in urban neighborhoods can directly affect the health of African Americans. As she writes, in some neighborhoods, children might be exposed to lead paint, have limited to no access to recreation centers or parks, and be taught in overcrowded classrooms. These environmental factors can influence physical and mental health.
To address health disparities, we need to understand why they exist, that they're not due to one single factor. They're the result of policy decisions we make as a society. They're due to the environment, health education, insurance and access to care, access to healthy food, and stress. Those stresses are actually experienced disproportionately by people who are poor and people who have been historically disadvantaged in this society.
In the 50s, we didn't have many choices as far as healthcare. The healthcare system then was limited. It was not good for us. And medicine costing so much that my family says sometimes, will I eat or will I pay for my medicine?
Today, 30 million people still remain uninsured, and about half of them are people of color. One of the specific reasons that people of color are disproportionately likely to be uninsured today has to do with the fact that 14 states have refused to expand Medicaid under the Affordable Care Act. More than 90% of the people who were locked out of coverage because of their state's refusal to expand Medicaid live in the South. And indeed, some of the states with the biggest Black populations are those that have not expanded Medicaid under the ACA. So bringing Medicaid expansion to the remaining states and taking other steps that continue to move towards universal coverage will reduce racial disparities.
Insurance and access aren't the only two things keeping minorities from going to the doctor. History, the conscious and unconscious biases of current medical professionals also play a huge part. When considering the history of Black people in the healthcare system, experiments like the Tuskegee syphilis study, which left multiple Black men untreated for 40 years, and people like J. Marion Sims, who performed experiments on female slaves without anesthesia, who was later named the father of gynecology, are the reason why Black people have this fear and distrust toward a healthcare system that is meant to heal our wounds.
I just want to make a brief comment to get back to the discussion about the health disparities in the African American community, because it really is very important. And the reason I want to bring it up, because I couldn't help sitting there reflecting about sometimes when you're in the middle of a crisis like we are now with the coronavirus, it really does have ultimately shine a very bright light on some of the real weaknesses and foibles in our society.
Solutions to these problems cannot just be medical, it's systemic. And that means everybody has to get involved.